I am an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf, and this episode is everything you need to know about midlife and beyond. Before we get into a few things I want to make very clear, definitely not giving any type of medical advice. If you have any questions about midlife or are just not sure what to do, make sure you go see your healthcare provider. And this episode has nothing to do with religion. So if you have any questions about your religion, make sure you go speak with your friendly neighborhood religious leader. This is the Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. So today I am super excited to have on with me Dr. Heather Quaile. Dr. Quaile comes to us from Atlanta, Georgia. So Dr. Quaile, for those individuals that may not know who you are, if you could just introduce yourself.
Hi, thank you so much for having me. I'm excited to be here. I'm Dr. Heather Quaile. I'm a women's health nurse practitioner, been practicing in the women's health space for about 2 decades now. And I have my own practice. It's called the SHOW Center, the Sexual Health Optimization and Wellness Center. And I really focus around sexual health, the midlife woman, thyroid, weight loss concerns, kind of really taking a trauma-informed lens. And I'm also I have a big platform that I just put out called the Q Spot. It's education for women's health providers to kind of find a space for more evidence-based information around hormone care, weight loss, starting a business, all the things that are always so hard to navigate everything in the women's health space.
That's amazing. I didn't even know you did that. That's fantastic. I'll have to connect with you offline about
Yeah,
that.
what is launched on the 26th, actually. So it is kind of new. I haven't shared it out it's out there in the world now, but I actually launched it on the 26th, which was the 5 years of my show center. And it also was the day that women got the right to vote. So I thought it was just really fitting that was just the right day to kind of launch. It's kind of been my huge summer project.
That's amazing. That's amazing. Yeah, it seems like one heck of a project. So that's fantastic. Well, thank you for sharing that with us. So, I often talk on here about menopause and perimenopause, and I've had so many providers come and talk about, that important stage of our life, and one that a lot of people that I know, because those are the people that I'm surrounded by, are also going through it. So maybe for those individuals that, are just hearing about perimenopause and menopause for the first time around, how early do you think menopause symptoms can start, and what's quote unquote normal versus concerning?
Yeah, and I'm sure you've done this on your podcast, but real briefly, menopause is a 1 year cessation without your cycle. Average age for most women is right around 51 and a half to 52. But the peri symptoms and the perimenopause, which is the complete chaotic, crazy time, is usually several years prior. And for a lot of women, some women, it's like that 4 to 7 years prior, but it could be upwards of like 14 years prior. So on average, the average person is going through it usually in their 40s. But occasionally I do see those women in their late 30s that are starting to kind of go through some of those changes that are happening in perimenopause.
Okay. Yeah. I haven't seen too many women yet in the late 30s, but yeah, absolutely. You're right. I mean, it can definitely happen, as we know, in the late 30s. So, yeah, I guess, it just changes, right? And it's just different for different women. So it's so important to make sure you go to a provider that's not going to dismiss you. Now, there are some women that I've seen where the hot flashes last a very long time. And I had one woman come to me that was not on hormones in her mid 60s that was still having hot flashes. What do you think? Do you think like hot flashes, brain fog, mood swings last forever, or do you think they can be managed?
I do think they can be managed, but I think it needs to be looked at kind of from an optimal perspective. There's a lot of like misinformation that's out there, and I follow a lot of the Menopause Society guidelines, but they're also really conservative leaning. They're always like, oh, well, we don't need to check blood.
Right.
And I'm a big blood tester. Like, I'm not this crazy, like, oh my God, we got to check your urine or do a Dutch test or do saliva, but I'm a big blood tester. Part of it, yes, I do check your hormones, but I think that you got to get to the root cause. Is there other concerns that could be causing these hot flashes that are going on with a patient? Like, is it their thyroid? Is it their ferritin? Like, I'm doing a big series right now on ferritin levels and iron and all the things. But again, if they're not kind of being optimized, what else is going on. When they start kind of hitting in those later years in the 60s, I think we need to delve into much more of the nuances and see, like, okay, you haven't had hot flashes, or have you had them all along and they've been so poorly managed, and maybe you do need some hormone therapy that will help that 100%. But I think it's really important to kind of look at what's driving the hot flashes, if you're not in the cruxes of that perimenopause to menopause transition, and what else could be going on. But I'm not anti doing them when someone's in their 60s, and I do think that hormone therapy can be very preventative and help with a lot of those symptoms, like the hot flashes and the brain fog and all the other things.
Yeah, yeah, absolutely. I think you're so right when you talk about, really trying to figure out what's causing this and, what are the hormonal changes. Maybe it's something going on in their family or something else of personal struggles that they're having. So, right, like what is actually precipitating these hot flashes?
And I think too, with just the brain fog, like, I'm not against SSRIs and anti-anxieties and ADHD, but I think also with so much stuff that's in social media right now, everyone thinks that hormones are the be all end all. It's going to fix everything. And I usually will tell people, like, I want you to have an 80% improvement in symptoms from when you started with me, but hormones for some may not be the catch all. Like, they may need an SSRI, they may need an ADHD med. And I think that that's important, to not throw them out at first line, but to actually think that they may need a part of that in their toolbox.
That's a very good point. I think that you're absolutely right. I think that, a lot of people think that once they go on hormones, everything is going to be fixed, like their brain fog, their anxiety, their depression. And I think it does absolutely help. But you're right. I mean, they may have had this anxiety and depression for a long time, right? And the hormones, maybe perimenopause made it worse. And so now they just need something, along with their hormones. They may still need their antidepressant or the anti-anxiety meds, or whatever else they were using to help manage all the symptoms they were having.
Exactly.
So do you think that obviously you and I both prescribe hormones, so we do think that hormone therapy is safe, but are there some people that you absolutely would not consider hormones for?
I think it depends. So, okay, occasionally, like, I tend to find, and you're maybe in that same boat. A lot of my friends see perimenopause, and I don't get tons and tons of peri. I'm seeing more and more in my personal clinic menopause and postmenopause, and it's probably kind of where I fall age wise. I always say people want to go to someone who they look like or who they kind of can jive with. So I talk a lot in my Instagram, for example, on how I'm a postmenopausal woman. This is what I'm going through. And so I think that's where I correlate. So for the women who falls over the age of 60, and they've never done hormone replacement therapy, is it a hard no for me? Absolutely not. I don't think anybody is a hard no for me unless they have had, like, maybe a stroke history that we need to evaluate. Do you have any unexplained vaginal bleeding that I don't know what it's causing it? But I have these little wickets that I will hit with patients, like, okay, you are over the age of 60. Should we get a calcium channel score? Should we get a cardiac intima testing? Are those parts and pieces important? Yeah, sure. The problem is, though, is we don't have good data. Like, what do we do with them once we have them? I've spoken to a couple of my, like, amazing colleagues, Jim Simon, for example, that menopause whisperer. And I've kind of said to him, like, okay, Jim, what do we do with this once we have this data? And can I still prescribe hormones? So I think it just depends patient to patient. Most patients are not a hard no for me. But again, it comes really down, as you know, to that shared decision making. I think I am much more rogue on certain things, where I'm like, sure, I'll give it to someone over the age of 60. And nothing is ever a hard no until I've proven, okay, I'm not super comfortable with that. Let's go get a workup.
Yeah, yeah. I remember, you and I both were at Ishwish, and actually, you were the education chair this past year. Kudos on doing such a great job with
Thank you.
that conference. I remember, and I think you were perhaps in that room as well, where there was that gentleman, the gynecologist from Miami. I don't remember what his name was, but he had done that research on women prescribing hormones to women that were over the age of 60, and he was getting calcium scores on them before he would give it. And so if they had a calcium score of 0, he felt totally fine about giving it to them. And if they were kind of in that middle of the road, if their score was, then he would do it with, obviously informed consent and risk versus benefit ratio and all of that. And then if they had really a high score on their calcium score, then I don't believe he would, give it to them. I don't know. Do you remember that,
I don't
gentleman?
think I was in the room for that, to be honest, because I was running around like a chicken
Yeah,
with my head cut off at a swish, as I'm sure you know, being a chair of a conference, it's
yeah,
crazy. But I do know, like my colleague was like, okay, well, if it's at 300, maybe you put him on an aspirin, or maybe you put him on a statin. But then he kind of caveated it: is this really more for provider Q&A, CYA, and to make you feel better? And really, do we have guidelines with it?
yeah,
Um,
yeah,
Ideally, a lot of times I want to avoid a statin if I can. I'm not anti-statin either, just like I'm not anti-SSRIs and anti-anxieties, but we know that there are side effects with going on a statin. That why is menopause hormone therapy often not the gold standard? I also kind of go back to my education and training over the years. I'm big on taking everybody's course. I've taken Heather Hirsch's, I've taken Jackie's, I have my own course, I've taken some of the functional medicine stuff. I want to know what everyone's doing in this space, because I feel like we were really poorly educated in our training, and I just want to be an educated provider on what all my patients could bring to me. But in Heather Hirsch, she said something that really, really stuck with me. And she said, we've been making estrogen, progesterone, testosterone in our bodies forever and ever and ever. So now, like, why can't we take it? Why are we going to put them on a statin first line? Why are we going to put them on an SSRI first line? One of the things also that our friend Rachel Rubin will say is, did we take their ovaries out for this condition? And if we didn't, and we left those ovaries, then why can't they have hormone therapy? And those are the two things that always go through my mind when I'm discussing like hormone therapy with anybody. When they fall after the age of 60, yeah, maybe the risks and benefits, that we have to have that discussion. But again, it's never that hard, no, because I remember those things constantly in my brain. Now, if they don't have their ovaries anymore, and it was because there was cancer or something traumatic in that respect, then that's a different conversation. But when I think about statins and I think about SSRIs, we know all the risk factors and the side effects on statins. And then our friend Kelly Casperson was telling us in one of our text chains, like, does anyone ever talk about osteoporosis with SSRIs? I went down a rabbit hole one day, like 6 months ago, because I didn't even know this.
yeah. Yeah, I didn't know. I mean, what? So she's saying that there's osteoporosis with
Yep.
SSRIs?
There is a huge risk factor. Long term SSRI use leads to osteoporosis. You need to go down a rabbit hole, because I did not know this until
I
about
didn't
six
know.
months ago. Never learned it. First time I ever heard it was out of Kelly's mouth.
Yeah, maybe I missed that. I don't remember her saying that. Wow. I think, sometimes we have a lot of talking in those
We have
chats.
a lot of work to do, my
Yeah,
friend.
we do, we do. Wow, I'm glad you brought that up. That's so important. I think I must have missed that. So what do you think are the best, when people come all the time, right? I'm sure they come to you too. They probably say, hey, I don't want to take hormones. What can I do naturally to support my body during menopause? I don't want to take meds. What do you say to that? How do you help them?
It's funny because someone just asked me this just this recently, briefly
Oh,
today, and it's never going to be like, oh my gosh, you have to take them. I have plenty
of
of people
course.
that are scared to take them, but I feel like what I always tell people and what I always say in my social medias is that every woman deserves the conversation on hormone therapy and what it can and cannot do for you, and what you're looking to get out of it. And if at the end of the discussion they're like, oh, I didn't know that, or oh, I feel empowered, no, I still don't want it, then we can talk about supplements. But supplements are never going to kind of be that gold standard. Sure, magnesium, vitamin D, vitamin B, and even iron for people with ferritin levels, I think are really, really important. But we also have to remember that supplements are not FDA approved either. So people think, oh, well, I'll supplement my way out of perimenopause, menopause, and it's safe. But we they're not as widely studied. They're not FDA approved, and so there's risk with anything you do, and that's kind of one of the discussions that I have with patients when we talk about supplementing or naturaling our way out of everything.
Yeah. And you know what I tell people as well is that, with these supplements, right, you're not going to get the benefits that you get with estrogen, right? You're not going to get that support for your bones, your brain, your heart, your colon, your joints, GSM, all of that stuff you get with estrogen. You're not going to get that benefit with like, a supplement with ashwagandha or black cohosh or something like
Yes,
that, right? So, I think it's
100%.
really important to know, right, what are the risks, what are the benefits, who's a candidate, who's not, and then, really just make an informed decision. And that's what I tell patients all the time, especially those that are hesitant. I said, I want you to do whatever you feel comfortable doing with your own body. It's your body. It doesn't affect me, but I just want you to be informed so that you can make, an informed decision, an educated decision, and then it's your choice.
Absolutely. And you bring up the topic of GSM, and I really want to quickly say is that GSM is just a naturally occurring phenomenon that we lose our estrogen. We're going to lose it in our vagina and in our vulva. And there are moisturizers and there are things over the counter that are natural that help with it, but nothing is ever going to replace that dryness, the irritation, and anything unless you replace it with estrogen. And I think that kind of if at least if patients are like, I don't feel comfortable taking hormones, I'm really big on GSM because you cannot fix the changes and the bladder symptoms and the discomfort that happens in our bodies with just a moisturizer. I think they're important. I think they help. But vaginal estrogen, as we know, it's not systemic there. We're trying to unbox that labeling on there. And so at least that's one of my parts and pieces that I try to get.
100%. I say that all the time. I said, even if you don't want to do it systemic, I said, just make sure you take care of your vulva, and actually two patients that I've just seen, one today, right before this podcast, and one yesterday, both told me that they were on systemic estrogen, but they were not given vaginal estrogen, that they were told they didn't need it. And I was like, no, 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 absolutely. You absolutely need it. And the one actually from today was actually getting cuts in her vulva and on the outside. And she's like, yeah, I noticed my tissue was much thinner and I didn't know what that was from. And I was like, no, absolutely. You need this, vaginal estrogen. It's so, so important. And I agree with you, right? Like you really need to protect your vulva and make sure that you don't get these recurrent UTIs and pain with sex and
Yeah,
whatever.
and I think part of it too is there's so much misinformation out there, and a lot of the pharmacists. I'm not here to bash pharmacists, but they're telling a lot of our patients you can't do both.
Yeah.
And yes, you can. Like you can do vaginal and you can do systemic because they work in different actions and mechanisms, and they don't have the same effect on the body systemically.
Yeah, absolutely. And you know what? I will tell you something, Heather. I had a patient a few weeks ago that came in and told me that her gynecologist, okay, so this wasn't like just some random person. This is her gynecologist, told her to put Crisco in her vagina for vaginal dryness.
I've had some sexual medicine people say like Crisco for certain type of meds as a carrier base if you get it compounded or to help with just lubrication during intimacy. Like obviously it's going to degrade a condom if you use that, but like for vaginal dryness, no. But I'm not going to say 100% no on a Crisco for like lubrication if that's all you had.
Yeah, I
But
guess. I mean, but we've heard like I'd heard of coconut oil. I'd never heard of Crisco, but like he's telling her to put the
yeah,
Crisco
not for
in every single day for her vaginal dryness.
no, no, no,
Yeah.
no, 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 no,
So
no.
I was like, what the heck? So tell me this. Now, we know that, a lot of times women have pain with sex, and, it's a lot of times that can happen. And, we're so lucky because you and I are in this group chat with individuals that do a lot of the research, right? So with Jill Craft and Rachel Rubin, who did that gender urinary syndrome of lactation. And so, when sex hurts after menopause, what do you think can help? And I know you mentioned this a little bit. So you talked a little bit about the moisturizers, the lubricants. What do you tell your patients?
So, one of the biggest things I start with, and I guess it's just the ISHWISH in me, the International Society for Study of Women's Sexual Health. I know you've probably talked about it multiple times on your podcast, but it's definitely a medical home for me. Um, it's kind of been ingrained in my brain. And so I always start by saying sexual health is a human right. Sex should never, ever hurt. And when it does, you need to get to the root cause and the bottom of it. Oftentimes for our perimenopausal women, they do have some discomfort with intimacy, and it can be hormonal in nature. But again, it's really important to kind of get to the root cause. Like if you add hormones back to the tissues, to the vagina, to the vulva, and it's not solving the problem, then you really need to get into, is it a nerve related issue? What does that look like? Where is the pain? And that's why it's so important, if you're not getting your needs met, is to really kind of go to the ISHWISH Society and really find a sexual medicine provider that can help you navigate, because again, sex should not be painful. And oftentimes in that menopause transition, it's usually hormonal in nature, and things such as estrogen and yes, testosterone, we can get into that a little bit more, are so important for our vulvar and vaginal tissues. And they do make it so that it is more, so that intimacy is not painful if it's from a hormonal standpoint.
Yeah, yeah, you're absolutely right. And, when hormones, when you give back the hormones and say we give back the estrogen and testosterone, and just what you were mentioning, right? Like if that doesn't take away the problem, then you have to really take a look at, is it the muscle? Is it higher up? Is it, right? Is it like in the spine? Is it in the brain? Is it, where is that pain stemming from? So you really have to do a lot of work and become like Rachel says, right? Become a sex detective and figure that out. So in midlife, we know that libido often changes, right? And we just had one of our colleagues was saying that that was the biggest problem that her husband noted when she was going through perimenopause, was that her libido had really tanked. And so, do you think for libido, it's just hormones, which I know it. I know what you're going to say, but of course, but is of course, we know it's not just hormones, but what do you think could be the other cause of low libido?
So I think low libido is very multifaceted. And I think that I always tell my clinicians when I'm training them, sometimes it's a hard conversation to bring up. So one of the things that I always do in my trainings is saying, if you can, like you and I are sex med people, so of course we're going to talk about it, and they know when they're seeing us, we're going to talk about it. It's on my intake forms, it's in my questionnaires. I'll spend hours talking about orgasm and libido, but for someone who's primary care that may be listening, or for our listeners that are not even medical, that are just lay people that listen to your pod, I think it's really important that healthcare providers put it on the intake forms and ask, even something as simple as the DSDS, the Decreased Sexual Desire Screener. We know that that screens for hypoactive sexual desire disorder, or HSDD, as we coin it. It asks 5 simple questions. If you answer yes to any of those 4 first questions, then it is generalized HSDD, and then you decide, like, is it acquired? Has it been lifelong? What does that look like? But anyway, to kind of answer that question, I think that's the first place to start, is to really have it in the intake form so that patients can feel seen and heard, and that the provider can say, hey, I see that you do have some sexual health concerns with your libido. I want to talk to you about it. Maybe an annual is not the proper place, but kind of to get to the root cause. And then the first question I ask my patients right off the bat with HSDD, the most important question to me is, there's a lot of things I can fix with HSDD, but I need to know, do you actually like your partner? And I think if you, like you and I have both been through sex counseling sessions, and I think, and we are trained to be sex counselors. You did the Michigan program,
I
right?
did. I
Yeah.
did. Yeah.
And I did a different program, but I think that's where we wear that lens as sex counselors, is that we get to wear these hats by being a medical person and a counselor. So when you don't know, when you don't know if there's partner issues, that's the first thing that needs to kind of get right out in the equation. And as you know, most of our perimenopause and menopausal women that bring that up, they're like, I love my partner. I want, but I don't feel like I'm in the mood. And so that's true HSDD. And we can kind of help kind of work through that and get to the root cause of what's causing that. And there's many things. It's really hard in midlife. One of the things I had talked to someone about today is that Most of us that hit this midlife time are in those 40s, 50s. Maybe we're empty nesters. Maybe we're sandwiching our generation, caring for our older children while maybe caring for parents. We're at the pinnacle of our career if you work outside of the home, and life is just kind of falling apart. And you have all of these moving parts between trying to be a good person, maybe a good clinician, a good wife, a good mother, a good parent, a good daughter, a son, whatever. And as all of these pieces start falling on you, the last thing you're thinking about is sex, because so many people need things from you. There's so many parts to HSDD. I always say a lot of providers can care for people with HSDD, but like there are so many reasons as to why HSDD happens.
Yeah, I love it that you just mentioned, I want it, right? And that I think is the biggest problem for some women. And, I had somebody actually yesterday come in and she was telling me that she has not had sex with her partner for 10 years. And I said, "Does that bother you?" And she said, "No, not really."
And
I
that's the key right there. If it
said,
doesn't bother them and it doesn't cause distress, then it's not an issue.
exactly.
But if it does bother you, or it bothers your partner and you love your partner, then that is HSDD.
Yeah. Yeah, absolutely. Absolutely. And I think that's the key distinction right there, what you just said. So that's so important to know and understand. So, what treatments do you think are available for women when they feel like they've lost their spark? What do you tell women?
So, one of the things also that I wanted to say, because I'm sure you see this with a lot of your community and who you see in your practices, I think we honestly need to go back and really define what intimacy is and what that looks like. I think we have got into such norms in our society, especially around heteronormative sexuality, is that it's penis and vagina, and that's the only way to have intimacy, and that's supposed to lead to orgasm. Well, great. It leads to orgasm for most men, probably 80% of the population. But for women, I think really redefining intimacy, as we know, most women do not achieve an orgasm through sexual intercourse, through penetrative means. And I think redefining that is super important as we kind of navigate and do treatments to help patients. Is part of that treatment, and you and I know, wearing our sex counseling lens, is really defining that issue of intimacy and what does orgasm look like, and talking to women about how do you expect, if you're in a partnered relationship, for them to know what pleases you if you're not comfortable with exploring your own body and knowing what pleases you yourself. So breaking down taboos of masturbation, that's a big thing that I spend a lot of time in. Breaking down taboos on what United States thinks that American heteronormative sex should look like, breaking down what intimacy looks like. Those are all big pieces in this. And then the tools also in our toolbox, of course, are going to be hormones. We have hormonal options, testosterone, balancing out estrogen and progesterone to be stable. I'm a layerer with my hormones, so I usually start with one. Testosterone's often the last piece I add in, and it tends to work better when I have the others stable. And then, of course, there's the non-hormonals like our flubanserin and bremelanotide that exist out there. And then there's some other off-label things, of course, that we can do for that.
Yeah, I think, I love how you say that we need to redefine what intimacy is. We know that there's so many different types of intimacy. We have emotional, we have physical, we have intellectual, we have experiential intimacy, right? And all of those are so important in a relationship. And, it's just, it's hard when individuals just, make it seem like the only type of intimacy is this physical intimacy. And if you don't have it, then you don't really have a relationship, which is not true. And I love the fact that you said that, we need to normalize masturbation. I think you're absolutely right, because it's funny. I saw a patient the other day and I told her that her homework was to go home and masturbate and figure out what she likes, because she was telling me that she has never orgasmed. And she was a young girl. She's about 25, 26. And she was saying, I've never experienced an orgasm. I don't even know what that's like. And then I went ahead and I was asking her about masturbation, and she's like, "No, I don't do that." And I said, "Well, I think it's time that you did, because it's important for you to know what you like so you can tell your partner." And I said, "Guarantee the people that you are having penetrative intercourse with," I said, "they probably don't even know what a vulva is. They probably don't know your anatomy. They probably don't know where the clitoris is." And so I said, "You need to go and figure out what you like,
Mhm.
so that then you can teach somebody else what you like.
And I think we have to break down the barriers not only on masturbation, even just saying, "Go get a mirror and go look at your female parts." How
Yeah.
often do you explain that? Like, "Here's your clitoris, here's your hood, here's your vulva, here's your urethra," and so many women don't know,
Correct.
um, any parts of that, but I think also the tools in our toolbox, like vibrators and things of that nature. I think there's so much taboo around vibrators where, especially in midlife, I'm always like, they are a tool to help with blood flow. You would use physical therapy, like to go get your arm taken care of, and they use TENS units and vibration and all the other things. So why wouldn't you use it on your female parts to fix things?
Yeah. Yeah. Absolutely. Absolutely. And I think that's such a good point that you bring up. And so, that's a great segue into, orgasms. So, can menopause affect orgasms and can sexual function really be restored?
I think that it absolutely can. I think that our research in orgasm is extraordinarily limited. As you know, in ISWISH, Dr. Goldstein, like the GOAT who trained me, has talked quite a bit about new novel approaches that are coming out. There's a lot of different medications, but it's one of the questions when I meet with my women that are in midlife is, tell me about your libido. Is it diminished? What does it look like? And then the next question immediately after that is like talking to them about sexual pain, bleeding. But what is an orgasm like for you? Is it blunted? Does it take longer? And most of my women will tell me, yeah, it's definitely become blunted, or it's taking a whole heck of a lot longer to achieve an orgasm than it used to. And so we absolutely kind of talk about that. I think that, again, normalizing the relationship about what works and what doesn't, bring a vibrator in. It does help the blood flow. It does help the stimulation. And because the clitoris and all the tissues get less estrogenized, like, you may need some vibration in there. You may need vaginal estrogen. I think that we can improve orgasm, sex, libido, and arousal in midlife. Like, I think that there's a way to do that, because I think you should like take advantage of maybe this midlife, kids are out of the house, empty nesting, and really kind of getting in tune with your body. It's maybe the first time, even in these long heteronormative relationships, that you're like, you know what, I'm going to go explore my body, and then I'm going to feel comfortable telling my partner, because we've been together for X number of years and I can talk to them about anything. So why shouldn't I be able to talk about my intimacy and what feels good for me? And so that's kind of how I try to kind of change that lens in midlife. So I do think I honestly think midlife can make intimacy better if people are willing to put in the work to have the conversations with their partner and explore their own bodies.
Yeah, and if we can get rid of that shame and taboo, right? And that idea that like sex is dirty, shameful, wrong. And for some individuals that grow up in very sex negative environments or communities, that is a thought that has been ingrained for so long, right? Even taking a look at their own anatomy is considered to be dirty and wrong, and that you shouldn't be doing that. And so to, really work with those thoughts, right? Because I think that it really stems from the thoughts of like, what do we think about sex, right? What do we think that, is it wrong? Is it dirty? And if it is, but why is that? Right. And then if we're able to change those ideas and to help somebody that is sex negative to become, instead of focusing so much on sex positivity, I actually focus on sex neutrality, right? At least coming to that, because it's harder, I think, for somebody to go a whole 180 degrees from sex negative to sex positive all of a sudden overnight. And I think that, maybe coming to a point where they're sex neutral and then eventually working towards sex positivity is perhaps, a way that we can help women that have grown up with a lot of sex negativity.
And I think that's where wearing our counseling hats, like, I think anyone who goes in the sexual medicine space and wants to do this day in and day out in their practice, I think wearing these counselor hats are so big for us, because where we are different, like, we know that when you send someone to a sex therapist, they're very hands off. Like, I want to debunk anything. Like, you're not going to go in a sex therapist and they're going to watch you have sex. Like, that's sometimes the things that people think. And that's obviously, as we know, not the case. But when they come in and see us, we kind of draw this very interesting line. Also, being medical providers, we do annuals. We put our fingers in a woman's vagina to feel her uterus and her ovaries. So we kind of wear these weird boundaries where we get to be sex counselor and medical provider. But I think it's this beautiful meshing, not because we want them to come in and show us how to have sex. That will never happen in a place that people come to see us, but we can really get to the root cause as they're working through some of their sex counseling stuff that we can help them on. Hey, let us actually do an exam and make sure that there's not a dermatologic condition or a problem that we're not seeing, or maybe your tissues are really dry and we can help that from a hormonal aspect. So I think that's kind of where wearing both lenses, if this is going to be your day in and day out, makes a lot of sense. And because it really, I think we help in a lot of ways to normalize things and really take a trauma informed lens.
Absolutely, absolutely. And I think that anything in sexual medicine, right? I feel like you always need like this medical professional, right? Whether it's somebody that can do your exam or whatever. I feel like you need a medical professional, you need a physical pelvic floor therapist, and I feel like you need a sex therapist. And all of
100%.
us, serve different functions, but all trying to get to the same goal of really helping our patient out. So you're right.
100%.
Let's talk a little bit about you being the education chair for ISWISH this past year. So, why don't most doctors talk about sexual health, you think, with women? And how is ISWISH trying to change that?
Yeah, so Ishwish is doing a lot of work with getting more medical people involved in the society. And it's like I said, for me, it's a medical home. And it's awesome because it doesn't matter whether you're an MD, a PA, a nurse practitioner, a physical therapist, a sex counselor. We want everybody who wants to take care of women in sexual health to be in our society. We're extremely biopsychosocial. And you hit on that when you said we need a medical provider, a sex therapist, and a PT often in the equation when we deal with sexual health. And that really comes from the mantra of the society that we are both a part of. I think the problem why people are uncomfortable talking about sexual health is for a multitude of reasons. There's tons of taboos in our society around it, as we've already talked about. They either haven't discovered Ishwish yet, so hopefully hearing the podcast, they will. And number two, it takes time. And some of the things that we have in the space, they work and sometimes they don't work. And I honestly think that doing gynecology for all of these years, sexual medicine, in particular sexual pain, is probably the hardest thing I've ever done in my career. And I still have to go to my colleagues when I'm stumped, and I'm stumped a lot in it because because it's just such new and novel information. And so I think that providers are really scared when a patient says, like, I'm having sexual pain, that they just kind of lump it out as, well, I don't know how to take care of it. So, and I don't even know where to send them. And I think that that's where a big part of the problem comes from.
You're so right, because there's so many of us, right? Even as a gynecologist, that I've done, 4 years of residency and all this stuff, and we don't get. I didn't,
Yeah.
I
How
don't
much
want to.
education in sexual health and menopause did you
Nothing,
get?
nothing, absolutely nothing. And, zero. So, and I hope that things are changing. And actually, I give lectures for a medical school here in New York. So I know that things are changing because I lecture on female sexual dysfunction and on menopause. But I can tell you for the most part, most individuals do not get that. I just gave a lecture last year, or actually it was rather earlier this year, to second year residents, OBGYN residents, where I did my residency through Michigan State University. But, it's just not common, right? We just don't know. And we don't, like, I actually feel really sad that I just discovered Ishwish like 4 years ago, when I started taking my course through the University of Michigan. And I wish I would have known about Ishwish like years ago, because I just feel that I've just gained so much from it and I've learned so much. And it's just such an incredible, organization, and it's so much fun. And there's great people like you that are there. And I just wish, the only thing I would change is I wish I would have known about it sooner,
Yeah, I
but
wish more people would have 100%. And I think the other problem is something really honed in with me this week on social media. You know how we always say, like, if you're not being heard by your provider, it's time to go find a new
yeah,
provider.
yeah.
Um, a layperson said on one of the comments, and it has really obviously stuck with me all week long because I can't get my head past it, is why are you all continuing to say to get another provider? Why are more providers not trying to go back and get the education that they need to
Mhm.
be better providers? And
Yeah,
I
that's
thought that that
very good
was
point.
really brilliant coming from a layperson. Um,
Yes.
and I think that it comes down to one of the big things that I tell clinicians that I train is like, I'm so glad that you're going through the training and that you want to learn these things for your patients. But one of the other things I always put out there is if you're not comfortable in the spaces, find the people that are and be honest. I think there's that problem that providers don't feel comfortable being honest, like, this is not my wheelhouse. And I'm never afraid to say that. I'm always like, that is not my wheelhouse. Like, even in sexual medicine, I know when I have hard cases that maybe PGAD, for example, that persistent genital arousal disorder for your listeners, I know to call my friend John Vogel. I'm like, don't spend your money seeing me. That is not my wheelhouse in sexual medicine. You need to go see my bestie down the road because he's your guy. And I think that if clinicians would just be honest with that or go back for the training, I think we'd make a big stride for women.
100%. You're so right. And I think that, you're not, yeah, medicine is so funny, right? It's so funny because if you don't feel comfortable doing something, you're almost taught in medicine to not say that you're not comfortable
Fake
because
it till you make it.
right. But you're almost taught because it seems like you're, um, either you're not smart enough or that you are that you're weak. I don't know. I guess maybe coming from like a surgical specialty, we just couldn't say that we didn't feel comfortable doing something, right? Because that showed like maybe you weren't strong enough, maybe this wasn't the field for you, maybe and like OB is so toxic, and I've said it so many times on this podcast. It really is. OB is very toxic. OB, you can't show. It's almost like you're weak, right? Like if you say to somebody that I can't do something or I don't feel comfortable, they'll just be like, oh well, maybe you're just weak, maybe you're just not cut out for this, and they'll slam you a different way. It's just, I don't know, that's the way that like it was in my residency. And so that's what always stuck, and that's honestly with the OBs and labor and deliveries, that places that I've done deliveries, and I just stopped doing deliveries like in July, that was always the perception that, was had with OBs, that you just couldn't admit that you didn't feel comfortable doing something, like it was a show of weakness.
Mm-hmm.
And
Yeah,
so I wonder, to your
I think
point.
it's that deep-seated like biases and things that we've just kind of built in, the imposter syndrome, all of it. I think it's hard to show that weakness, but I honestly think showing the weakness and just admitting like you're not the expert on everything and that we can't do everything. Like I have found that that vulnerability shows patients that you're just a vulnerable person also, just like they are. I mean, it's very vulnerable for a patient to come and talk to you about their sexual health concerns or their menopause concerns, and even to feel comfortable having that conversation with you. And instead of dismissing them and just saying drink a glass of wine or that's normal, just say, I really validate and I hear everything you're saying, but I'm not the expert and I feel like these needs need to be heard by an expert, and this is who I recommend in our area, or let me help you find someone, guiding them down the path. And I think and I don't think that it shows weakness. I think it shows that you're not the expert on everything, but that their concern matters to you instead of trying to dismiss it.
Yeah. And you know what I think that also shows is that you're humble, right? Like you don't have a God complex. Like you don't know everything. There's no way you can know everything, right?
Right.
And so when you just admit to a patient that, I don't know. And I think that just shows that you're human, right? Because you can't know everything. And so I agree with you. I think that, being vulnerable, just as the patient is vulnerable with you, shows that you're a human. And I think that's really important. How is research and education evolving in women's sexual medicine, and what do you think is on the horizon?
Oh my gosh, I think it's so amazing. Our good friend Dr. Rachel Rubin has put together a group of amazing medical students that want to be doing sexual medicine research research. It's called the Sexual Medicine Research. I think it's Team SMRT.
Smart or
Yeah,
something, is that the acronym?
SMRT, and they are doing such amazing work in the spaces around sexual health. If you want to get into research as a clinician, and you want something new and novel, sexual health is the way to go because we don't have a lot of research out there. We're getting there, but there's so much research that's needed. I just did a paper with an amazing student that is finishing up her medical student residency and actually one of our ISWISH advocates. And we just did a nomenclature change that we're putting out to a journal around the genitourinary syndrome of menopause, and that it really needs to be called something outside of menopause because, as we know, there's the lactation, there is cancer changes, there's for our gender nonconforming and trans patients, these changes that happen. So if you really want to get on the cutting edge of research, sexual medicine is the way to go. And I think that there is so much more coming down the path. Our amazing Dr. Gerwin Goldstein is actually going to be coming out with a pathway to care, and I know I'm forgetting the name of it, but it's all around orgasm and how to treat it. And it should be coming out by the end of this year, beginning of next year. So again, this is like new and novel drugs, of course, off label. There's so much off label in sexual
Yeah.
medicine because not only do people not want to talk about it, I feel like the FDA doesn't want to talk about it either. But that's
Yeah.
a whole other conversation.
So, how can women advocate for themselves, you think, when their doctor isn't trained in sexual medicine? We know that there are reproductive deserts throughout the United States, and we know that there's so many women, even to get basic GYN care, have to go out of state. I was just talking to a colleague of mine that's in Alabama, and she said that they don't have OBGYNs to deliver babies, within like an hour and a half radius from where she is. And she said, so patients are going that far to get just routine prenatal care. And she said that the ER docs in her town are so afraid to have to end up having to do those deliveries because those women live so far from the hospital,
Yeah.
So, I mean, that's prenatal care. That's OB stuff, but I mean, sexual medicine, I think it's even hard, even in big cities, right? To find like sex med docs.
Yeah. So we're trying in ISWISH to have more people trained. There's people like us that are fellows of ISWISH that are trying to train other people and get into those sexual medicine deserts. There's also people that have licenses in multiple states that are members of ISWISH. So that's the first place I would definitely go if it's a sexual medicine concern, hypoactive sexual desire, sexual pain, menopausal concerns. Of course, you can look at us at ISWISH. A lot of us are also dual certified as Menopause Society providers or certifications, but you can also look at the Menopause Society. Getting into the spaces around social media, obviously following people like us and then following our colleagues that we follow. We really try to put out evidence-based advice, but I know social media gets really, really hard because it's the Wild West out there on some of the stuff that's out there. So really kind of staying consistent with following people that you trust and then seeing who else they follow. And sometimes you can reach out in DMs or you can reach out in posts to say, who would you recommend? Because there are resources here in the United States. And I always try to be helpful about helping people find places.
100%, 100%. So, what is one piece of advice that you would give to women navigating this transition of perimenopause, menopause, and issues with sexual health? What would be that one piece of advice if you could give to them?
Listen to your gut and your instincts. Do not let yourself be gaslit or told it's all in your head. I think that is probably the most important thing, is that we do know our own bodies and that we're not feeling like ourselves. So if that's how you're feeling, you need to validate that that is a very, very valid concern and that you need to find someone that's going to listen to you and help you unpack it all and get you feeling better.
100%. Well, thank you so much. So Heather, for somebody listening and, she's listening to you or he or whoever is listening to you and they're like, wow, I love Heather. She is so amazing. How can they find you? Where can they find you? How can they get an appointment with you? How can they reach out?
So if you follow me on my socials, I'm at Dr. Quaile NP, DrQuailenP. That's my Instagram following. My practice, the Show Center Sexual Health Optimization and Wellness Center, is just www.theshowcenter.com. And then if you are a clinician that listens and you want more information on my educational platform for women's health providers, that is theqspot.net.
Amazing. I love it. Well, thank you so much. This was such a great conversation, and I'm so glad you were able to come on. And I really appreciate your time, Heather.
Thank you so much for having me. Loved being here today.
Thank you. So, well, we are done here, and it's been real and really intimate. And so, if you have any questions about midlife, sexual health, menopause, any of those things, make sure you go see your healthcare provider or go to menopausesociety.org to find a Menopause Society certified practitioner in your area, or go to ishwish.org to find a sex med provider in your area. Until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast, and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.